Thank you to everyone for joining us for this panel where we are focusing on the experiences of African nations in rolling out COVID-19 vaccines. Many countries across the African continent have leaned heavily on free doses from the COVAX facility, which are mostly the Oxford AstraZeneca vaccines, as well as several countries receiving doses of the Pfizer vaccine. The African Union has also secured Johnson & Johnson doses for countries to purchase, will be available starting in August, September, and countries have also made their own arrangements. But there has been mixed success in rollouts. Some countries were able to very effectively roll out doses they've received, while others have struggled. Some of the big challenges included inadequate funding for rollouts, quickly approaching expiry dates, as well as uptake among the populations. And with the COVID-19 crisis in India, the Indian government has restricted export of vaccines, which has cut off COVAX's supply to the vaccines produced by the Serum Institute of India, leaving many African nations unsure when their next shipment will come. To talk through all of this, we have Dr. Mihigo, who is the Immunization and Vaccine Development Program Coordinator at the World Health Organization's Regional Office for Africa. We also have Honorable Minister of Health for Sierra Leone, Dr. Austin Demby, Honorable Minister of Health for Ghana, Dr. Kwaku Agyew, Dr. Sabin Nsanzimana, the Director General of the Rwanda Biomedical Center, and Anstes Agnew, who is the Head of Health Systems at the Tony Blair Institute for Global Change. And my name is Sarah Jerbine. I'm a global health reporter here at Devex. For all of our listeners, if you can please use the chat feature if you want to introduce yourself, and the Q&A function to ask questions to our panelists. Closed captions can also be enabled by clicking below. So to begin the conversation, Dr. Sabin, Rwanda has been praised for its rapid rollout of vaccines, and your team began rolling out vaccines across the country only 2 days after receiving doses. How were you able to do this?
Thank you, Sarah. Thank you, everyone, great panelists, ministers, colleagues, and all who are following up. So this is a very interesting question. When we talk about vaccines rollout, and I would say that the first phase of vaccines, because as we speak now, there's no single dose of vaccine left over in Rwanda. We're just waiting to have the next opportunity to give this life-saving tool in public health, which is actually vaccine comes as number one. So the rapid rollout of vaccination in Rwanda has been guided by a few principles. First, we had to understand that the vaccines are coming here to alleviate a burden of a disease that if we don't do something, we will get more and more cost to incur. It's actually going to affect not only our health, but also our economies. So whatever doses is coming should not be kept into the storage. That was the principle number one. The principle number two is that we are not creating a new vaccine supply chain system. We already have a national vaccination program that existed for more than 2 decades that has been rolling out and implementing vaccines that are probably even more complex for children and for special targeted groups that are hard to reach. That this one was even quite easier to roll out if you think of these are adults, people easily to find out. Number three, as a principle for us for rapid rollout, was to engage all sectors, all programs, or everyone who was involved in COVID response had to take this as an additional opportunity to reduce the spread of the disease. See, the local government, the Minister of Health, the security organs, the partners, all the sectors, including private sector and the communities, were part of a committee that was coordinating on a daily basis. So speed, coordination, and understanding that this is a firefighting mode. So if we need to fight a fire, you don't want to lose even 1 minute, because the damages will be much more important. So that is how, when the vaccines arrived on March 3rd, just 48 hours after we had already started to vaccinate across the country, because of what I say, but also because we wanted to see how the demand of the community was quite high. We didn't want to lose that momentum, given the time we've waited for these vaccines. Understanding that people outside there waiting, for us to wait more time would create some kind of a gap between our health systems and the community, and yet the trust and the relationship we've built is all about how can we save even one single life timely. And the last aspect was that we should not be constrained by finances to roll out vaccines, because the losses, if we don't roll out the vaccines, are more costly. And we had costed our plan. We had made a plan earlier before. We had purchased vaccine storage, deep freezers for all type of vaccines. But there was still a gap in terms of resources and funding. But that, we say, this should not be something to block us to move forward. Because if you wait, then the cost will be even double and triple. So in brief, this is how we were thinking, and this is how, when we received the 290,000 doses of AstraZeneca and 100,000 doses of Pfizer, we quickly distributed. And after 2 weeks, we had almost finished all the doses. And now we're just waiting. It's another phase that, as a doctor, as someone in the health sector, don't want to be. It's uncomfortable when you think that there are tools somewhere and there's people somewhere and there is a disease that is around and you can't connect the three things together. It's really uncomfortable, and we're working with our partners, working hard to make sure we get more vaccines and we go into our second phase. Thank you.
Okay. Thank you. And Anstes, you're also based in Rwanda. Could you talk a bit about how smart data management played into Rwanda's vaccine rollout?
Thanks, and thanks to the Director General for his point. I think this point about not wanting to waste 1 minute is so critical. And while data had long played a part in Rwanda's health system, Rwanda did everything possible to shorten that learning curve and have data at the ready to move quickly. And data really played a role at every stage of the rollout. There were digital systems in place when vaccines hit the tarmac to track the cold storage and to get vaccinations into fridges, but quickly, really the same day, out to health facilities, and to track exactly how many doses had gone to health facilities across the country of AstraZeneca and Pfizer. The second then was having data capture. So as citizens arrived for their jabs, all of their data was captured digitally in a centralized system. This both meant that when citizens arrived back for second doses, there was clear record keeping and a quick way to identify exactly who needed to come back and when, but so that decision makers could make the choices about allocations of doses. So because each health center had prioritized having a data manager in place, having a tablet in place, it meant that as soon as healthcare workers at a health facility had been vaccinated, the district could call up local community health workers next, and then move on to teachers and other essential workers. And that data was there in real time about doses available. And it was data that had been collected well ahead of the vaccination campaign, so that there was really this ability to move quickly. And I think another really important piece about that data storage and centralization for COVID-19, it's as much about decision makers having at their fingertips the data on rollout to understand where scarce supplies are going, but also so that citizens can access their records, so that community health workers can follow up, so there's no loss to follow up. In Rwanda, it meant that community health workers could be proactively calling citizens and alerting them to changes in the schedule. One, for example, AstraZeneca was delayed. And it means that that data is there to facilitate global reopening, both for the healthcare system and the wider economy.
Thank you for that. Now turning to Dr. Mihigo, could you talk a little bit about kind of access problems when it relates to accessing vaccines across the African continent and what options countries might have when it comes to accessing doses, second doses to complete immunizations?
Yeah, thank you, Sarah, and good afternoon. And I'm really glad to join this very good panel with such high profile colleagues. Let me first start by saying that when we looked at the access really, and particularly we are talking about almost 5 to 6 months since we have started to see the global rollout of COVID-19 vaccines. Africa did prepare itself quite very well. Most of the countries, before even the vaccine started to be rolling out, and we've heard a very good example from Rwanda, had plans in place, had very clear targets to reach population. Objectives were there, and we have seen when the vaccine landed in the countries, immediately activity started. But the supply didn't really follow the ambitions that country had. And as of today, for instance, if you looked at the data that we have at WHO, it's quite concerning because so far, if we looked at the global level, close to 1.5 billion doses of COVID-19 vaccine have been administered, compared to only 28 million doses in Africa. So on average, that gives you around 2 doses per 100 people in Africa, compared to close to 22 to 23 doses per 100 people globally. So that really gap is unfortunately going wider as many countries are waiting additional doses, as we have heard from Dr. Sabin. One of the reasons of this gap has been, of course, the dependence that COVAX facility have had so far with the Serum Institute of India. Nobody could have predict what went on in India, which had to almost suspend the delivery of the vaccines. If we looked at what was planned to arrive in March, April, and May, we're talking about 160 million doses that was in the pipeline that unfortunately didn't arrive in the country. So I think that's a critical access, a critical issue in terms of supply. Our countries, even those countries that are doing quite very well, when we are looking at the overall coverage compared to the general population, they are still very low. I think the data from Rwanda, from Ghana, showing that there are less than 3 doses per 100 population globally. Despite the eagerness, despite the preparation that went on in those countries, Sierra Leone, we heard as well from the Honorable Minister, the supply are not following what the country are doing. And I think this is why at WHO we've been quite very concerned, and we really launched an appeal to the international community to make sure that a country in Africa can be supported to get the doses that they need to protect not only frontline workers, but also the people who are more at risk of getting the disease, dying from the disease, and ultimately have supplies that will help countries in Africa also to see the end of the tunnel and to start to reopen widely the economy on that. So very good progress last week during the Global Health Summit with the pledging of additional doses by high-income countries. But what we need for the moment, it's really to see those pledges being materialized in concrete delivery in countries, so that the second doses that are due already in many places can start happening. So just to give you a number, we need urgently at least 20 million doses of AstraZeneca to make sure that the country that have started vaccination can at least provide the second doses to the people who have received the first dose. So to not break that confidence, that trust that has been established by government with their population in delivering these vaccines, urgent action are really needed to make sure that a country can receive as soon as possible the vaccine. And we are working hard with not only the high-income country, but also to diversify the vaccine portfolio so that we are not depending on one product only. And if there is a problem, everything gets stopped.
Thank you, Doctor. And now if I could turn to Honorable Minister Demby. You, from what I understand, Sierra Leone received its first doses in early March. What have your experiences been like in rolling out the vaccines? What strategies have been effective, and what challenges have you faced?
So thank you very much, Sarah. I think our experience is derived or is informed by what happened with Ebola in Sierra Leone. As you know, Sierra Leone was one of the countries that was impacted the most, and there are lots of lessons learned from that. And so when we heard of COVID-19, the mitigation measures, except for the mask, were ingrained in people. And so it's not surprising that Sierra Leone was one of the last countries in Africa that had COVID-19 introduced, because I think we had all of these very effective mitigation measures. One of the challenges that we've had with vaccinations is just the fact that people are just really quite concerned that these are new diseases that they've never heard of before, and all of a sudden you're asking them to have vaccinations. And I remember in the Ebola case, people were saying they're actually inoculating us with Ebola virus, and that's why we're dying. So there's this real fear, deep fear in people in Sierra Leone, and deep skepticism as well. And I think we had to overcome that. And one of the key lessons we learned from Ebola is being a good listener. Don't come in with solutions that you think are going to work without really listening to people, because a lot of their concerns were deep concerns that if you address those concerns, you could turn the table around and we have them as strong allies going forward. In our case in Sierra Leone, we realized that people were concerned about the vaccines, and they said, if these vaccines are so good, why don't the president be the first person to be vaccinated? And so what we did was the president and all of the cabinet members, all of the leaders in government, all of the judiciary, everybody had a major launch event where everybody was vaccinated in public. And we all walked away with a biometric card that shows that you've indeed been vaccinated. The second issue that they had was, we're not sure about these vaccines. Are people going to be glowing in the dark? Are they going to be dying? Are they going to have all kinds of complications? And what we did was we reassured them that these are new products. The evidence and data that's available shows that the adverse events are very, very rare events. But what we'll do is we'll put in place systems of active pharmacovigilance for anybody that's been vaccinated, and we'll monitor and track them and make sure that if there are any adverse events that we're able to deal with it. And so with the combination of the confidence building by the president and the cabinet, the combination of that with the pharmacovigilance effort, and the fact that we took time to explain the science in very, very layperson's terms, we have a situation where people are very, very interested in being vaccinated now. We had vaccines from China. China gave us Sinopharm vaccines at 200,000 doses. COVAX gave us about 98,000 doses. And so that's another complication. What do I take, the Chinese vaccine or the AstraZeneca vaccine? We had to explain the science behind all of that and get people to a comfort level. We're at the point now where people are very interested, they're very excited, they're all bringing their relatives in to be vaccinated. We deliberately focused on high-risk populations at this point, and we're willing to expand, to constantly expand the eligibility criteria. But we're now worried because I think when we started, we're assured that we'll have the second dose, the second batch of the COVAX drug vaccines by early May. And we were promised 500,000 doses. And with that kind of resupply, you know, we could really expand as much as we want. But then we found out that what was going on in India, there were doubts now about the availability of the resupply. And there's potential gap in vaccines availability. So we have a moral dilemma now. Do we use up all of what we have and have nothing when potential wave of the India-like situation unfolds in our hands? Or should we really target and continue to utilize our vaccines at the highest risk populations until we're assured of the resupply component? So that's our moral dilemma we have now. High uptake, high interest, but we're worried that we may not be able to resupply. And one of the biggest concerns we have is if we have an interruption in our supplies after we've raised so much demand, so much interest, it'll be very, very difficult to re-engage later on. So we're asking Dr. Mihigo and our colleagues to really do everything you can to make sure we have the resupply. We'll be able to uptake all of what's given to us. Right now, we're at 1% vaccination of our population. We'd like to up that tremendously, and it's going to be very easy to do using the existing systems, but we want to be assured of the resupply. Over.
Thank you. And Honorable Minister Agnew, what has been your experience with rolling out vaccines in Ghana? And what sort of challenges have you faced? What strategies have been effective for you?
Experiences will not be very much different from what Leone is talking about. We had two plans prior to the allocation, even the allocation of vaccines from COVAX. We initially did our vaccine plan, and then later we did a deployment plan. And we were the first amongst the whole globe, the whole world, that got the COVAX vaccines, over 600,000 doses. We had planned to deploy with our traditional immunization structure. Our system was very robust. You know, Ghana is doing about 95% DPT3 coverage. So our system was quite robust. All we did was within a day or 2, 3 days, did refresher training for our vaccinators and added on a few more. We had a strategy. We had 2 cities where we had this pandemic hit most. The spread was very fast in the largest city, Accra, and the second largest city, Kumasi. So though we picked different groupings as part of our plan, the first highest risk, including health workers, we even concentrated in these 2 cities first. And we selected 43 districts from these 2 regions and just 1 district from the next aligned region to the Greater Accra, the central region. So we started our vaccination with health workers, the legislature, the executive, the judiciary. We needed to use high-flying civil servants and public officials because of our fear for hesitancy. We did some good interviews with people, and they were talking about they want the big men to do first. So the big men went in first. Our president did his first vaccination. I did the second day. The vice president did the first day. And so the Supreme Court judges and all that. And when this exercise was completed, we had a continuous plan. So our rollout was very smooth. Now, into about the 5th day, we had gone that much far. So people outside the 43 districts, especially health workers who had been identified to be in the first category of cohort of population, started agitating outside the areas that we actually zoomed in first. So we had to split our tackles to do health workers, people with underlying conditions, the elderly above 60 years, so we moved on. Teachers above 50 years were also included because we had open schools. So within the first 2 weeks, we had virtually completed more than 50% of the vaccines that were given us. And we didn't want to wait because we had assurances and indications. We were working together with UNICEF in country to be receiving allocations that have been given us from COVAX. Unfortunately, India hit, and it's like we got information that our allocation, the second allocation, 410,000, wouldn't arrive in March. Then they have given us within the first quarter to May, we will get about 2 million doses. So later in course of the period, when we had virtually exhausted all we had, we're not going to get nothing. We waited, May came, and then that is it. But we got some little extras from somewhere. MTN had some doses that were not being used in South Africa. On the African Medicine Supply Platform, this was distributed to some African countries. Ghana benefited. So we added on to 600,000 through that window. So after that, we had done close to about 966,000 doses had been administered in the first phase. Then we were waiting for a location we couldn't get deliveries. And then those who started 1st March came close to 8 weeks and we're moving close to 12 weeks. But from science and data, we decided to hold on, but we were not panicking until we started our second dose of 350,000. This was pulled from somewhere else through the efforts of WHO AFRO. I hear Congo wasn't administering very fast. So when they thought that it will expire.
Yeah, I think the Honorable Minister is frozen. We'll come back to him to finish up. Dr. Sabin, I wanted to ask you, so Rwanda was one of the few countries that received the Pfizer doses in the first allocation of COVAX. Did Rwanda have the cold chain infrastructure in place in advance to this, or what were kind of the steps that it took to receive these doses?
Yeah, we had these deep freezers even before the vaccine arrived, but we had planned to increase the number of deep freezers to augment our storage capacity for these vaccines when we were already following up on the conditions for Pfizer, Moderna vaccines requirements. So we had, in the meantime, I think it was almost at the phase 3 of the trial towards the end. So we purchased additional deep freezers because we knew that this is coming. It's going to be a key condition for being able to manage these vaccines.
Okay, thank you. The Honorable Minister from Ghana is back. So if you would be able to finish up with your statement, sir.
Yes, like I was saying, by Friday, we'll have exhausted the extra we got from the efforts of WHO AFRO. And we are waiting desperately to try to see where we can get extra vaccines from. We are making all efforts even to procure ourselves from sources that we thought we could get. We were pushed out of anticipation that we may lose our clientele who had actually washed away vaccine hesitancy and tried to take vaccines from even Russia. But all our efforts have also proved even futile. We can't get deliveries. They keep on giving us different delivery dates into August and September and July and all that. We have signed on to, how do I call it, self-procuring from COVAX, but of trying to assist countries that want to buy themselves. We have signed on to that. We have signed on and even put some money in advance for African Medicine Supply Platform, the AU window, for Johnson & Johnson, that will come in August and September and beyond, even 2021. So we are making efforts to even procure ourselves to the support of the World Bank, but we can't get nothing from nowhere. And that's our predicament. Now we are pleading with people who have got the first one, waiting for the second dose to panic. We are making efforts to get vaccines with assurances from COVAX and Gavi and everywhere, based on this strategy of dose sharing. The announcements from UK and the US, President Biden promising to release 80 million in 6 weeks. We believe that if that goes through the COVAX window, some of us that are desperate to get vaccines for even administering second doses may get them before we even think of expanding to do first doses for other cohorts of population. So that is where we are. Our system is quite robust, actually. And if we get vaccines, we wouldn't delay at all.
Okay, thank you, Minister. Dr. Mihigo, you've talked a bit about how COVAX is trying to diversify its portfolio. Can you talk a bit about that? And then also, what are some of the key mistakes that countries made in the first round of vaccine allocations that you hope aren't repeated when countries get new allocations of vaccines?
Yeah, thank you. Thank you, Sarah, for this question. Maybe before responding that very quickly, I think we heard a very quite strong message from the honorable ministers in Ghana, Sierra Leone, but also the Director General of Rwanda Biomedical Center. Countries are eager to roll out the vaccine if they've got supply. I think they need definitely some predictability in terms of the supply pipeline to maintain the momentum. We despite everything that was said at the beginning, I think that countries in this region did prepare very well the arrival of the vaccine. Now, with the pipeline, as you have asked, we have seen the situation in India, which was not predictable at all, and which has a very unfortunately negative impact in the supply situation for COVAX facility. Right at the beginning, the objective of the COVAX was really to diversify as much as we can the vaccine portfolio so that we can offer a much more broad range of products to the member states so that they can make their own informed decision. Luckily, we have now, out of the two newly approved vaccine for emergency use authorization, the COVAX has struck concrete deals now with Moderna for 500 million additional doses, which unfortunately we're not going to be ready right now. We are going to receive a small quantity, around 30 million, the fourth quarter and the remaining next year, but also a very good prospect with Johnson & Johnson, probably starting in July. We hope that these efforts are going also to be complemented by the what the African Union platform, the AVAT, is doing also through Johnson & Johnson to augment the capacity of country to deliver these vaccines. Now, on your last point on what are the mistakes that country did, I think we saw that there were clearly in a few countries a gap between the plans that were developed, very good plan on paper, and the micro plan that were meant to deploy the vaccine. I think most of the country now are trying to address that gap from the micro planning to really meet from the macro planning to micro planning so that they can target very clearly their intervention. Secondly, though we heard Rwanda clearly saying that financial resources at the beginning, though not necessarily sufficient, was not necessarily a big bottleneck for them. But unfortunately, we saw in many countries that implementation costs to facilitate the rollout of the vaccines were not there. So we're working with the World Bank, working with other partners through the COVAX to not only improve the supply, but also to improve the financial assistance to the country. And then finally, we heard about the vaccine acceptance or uptake in the country. So there's been a lot of challenges in terms of, I don't know if we can call it hesitancy, but also sometimes refusal of the vaccine. So we need absolutely to invest a lot of efforts in that area to make sure that we create that trust, confidence of the population to the vaccines once they become available.
Thank you. And that was the perfect way to round off this conversation. We've unfortunately run out of time, but it's been fascinating to get all of these insights into how vaccine rollouts are playing out across different countries on the African continent. So I want to thank you so much to all of our speakers for joining us, and thank you to everyone who tuned in.